Right, so today, kind of what I want to talk to you guys about, it's called evidence-based diagnosis. And I'm going to go into like a little bit of, Bayesian analysis, um, trying to figure out pre-test probability, and then the use of likelihood ratios to affect your post-test probability as well. So I'm going to go over just the general background of that stuff and kind of teach you a lot of the terms around it and how to actually use it in your diagnostic reasoning. And we'll kind of all mix this into a case of a patient with shortness of breath. Like this is a patient I saw, I think when I was a third year, that had a lot of, I thought this patient had a lot of like diagnostic utility in presenting for a case because there was a lot of different competing physical exam findings, imaging, things like that. And they had a couple different diagnoses that, we weren't really, or the person who originally admitted this patient wasn't really sure why the patient was so short of breath. So this is the case, and I'll read it out for you guys. So this is a guy I saw, he's a 62-year-old male. He has a history of hypertension, hyperlipidemia, non-insulin dependent diabetes. Oh, I didn't share my screen. Sorry, I've been away for vacation, so I've been a little bit off. Good? Okay, thanks, Amy. And he had a history of MI in 2017. He had a drug-eluting stent to the second diagonal, chronic kidney disease, stage 3. So he presents to the hospital with progressive shortness of breath. He was recently admitted about 2 or 3 weeks ago. 2 or 3 weeks ago, where he was found to be kind of short of breath on admission. He had a hemoglobin of 6.8 at the time. So he's given 1 unit of blood. He subsequently developed TACO. He was treated for that and he was improved, had an endoscopy that was negative and discharged on iron pills. He's found to have iron deficiency anemia. So he shows up to the ED. In the ED, this patient was shortness of breath. They were wheezing. They had this chest x-ray that was shown on the right of the screen here that said that radiology actually said that there is an air space opacity in the left lung apex, as well as, mostly just in the left lung apex, that they said was concerning for pneumonia. So the ED admitted this patient for pneumonia causing a COPD exacerbation. Those are his meds. Like I said, he has had MI, so aspirin, atorvastatin, carvedilol, glargine, metformin, pantoprazole. He was a smoker previously, but he's functioning independent, lives at home with his wife. So let's just kind of go into, I'm just going to do the background of, likelihood rate, like really Bayesian analysis and likelihood ratios. There's a really good quote by Osler, and the quote is that medicine is a science of uncertainty and an art of probabilities. What that quote kind of means to me is that people don't really present classically a lot. People present authentically, and they can have a lot of different competing diagnoses, different competing physical exam findings. And I think sometimes, it can be really hard to judge signal versus noise, what things are related to their disease process, what things are just red herrings. And a lot of times, when we're stuck in this situation, we approach these patients with intuition, with our gut feeling, which can be very prone to bias. So this is kind of what I want to teach you guys today is more of an analytical way to approach these patients, to approach findings and to incorporate those findings into what probability you think this patient has this disease. So the first term, this is kind of called Bayesian analysis. So the first term I'll present is pretest probability. So this is kind of how you start off with a patient. You see them, and then, this is a lot, intuition. You develop pretest probability. Say a patient comes in with, cough, shortness of breath. You say, 50% shot they have pneumonia. That's your pretest probability. It's kind of intuitive, right? And, this part's not too scientific, and a lot of people have trouble with this part, is that, you know, you're just kind of making an assessment of what the probability of disease is based on intuition, based on the information that you have so far. The next one is likelihood ratio. So kind of what is a likelihood ratio? So likelihood ratio is basically how powerful a finding is for ruling in or ruling out a disease. So a positive likelihood ratio, and likelihood ratio is very good because it's, you know, sensitivity and specificity are good in their own right, but likelihood ratio incorporates sensitivity and incorporates specificity, which is good because for, you know, a finding to rule in or rule out the disease, you want it to be sensitive, meaning that that finding is very, very common in patients who have that disease, but you also want it to be specific, meaning that that finding is uncommon in patients who don't have the disease. So likelihood ratio actually incorporates both of these things for telling you how well this specific finding can rule in or rule out that disease. So a positive likelihood ratio is sensitivity. This is how it's calculated, over 1 minus specificity. And negative likelihood ratio equals 1 minus sensitivity over specificity. So a positive likelihood ratio means how much does this increase the likelihood of this disease if this finding is present, and a negative likelihood ratio is how much does this decrease the likelihood of disease if this finding is not present. So how do you kind of the hard thing that I think people get messed up with is how do you incorporate this into your probability of disease and just basically your diagnostic or your really suspicion of that underlying disease. So you take your pretest probability. So let's say my pretest probability is 50%. So I start there, and let's say I have a physical exam finding that's completely useless, and it has a likelihood ratio of 1. So what that does is not change my post-test probability at all. So if it has a likelihood ratio of 1, that means it doesn't make it, that physical exam sign is useless. It doesn't make it that post-test probability of disease more increased or less increased. So let's kind of do the other likelihood ratios. So this is the way that you incorporate it, is that you actually will kind of take that likelihood ratio and you'll kind of use an estimation. And the estimation that is used is that a likelihood ratio of 1 doesn't do anything. A likelihood ratio of 2, so see it went up to about 65%. So 2 equals plus 15%. 5, a likelihood ratio of 5 for that physical exam finding, if it's present, increases by about 30%. So you see that it went up to 80, went from 50% to 80% right there. And for 10, goes up about 45%, roughly. And this is similar for negative likelihood ratios. So for negative likelihood ratios, how to estimate your post-test probability or your clinical suspicion of that disease based on the finding of that, based on that finding and what the discriminatory function of that finding is or what the likelihood ratio of the finding is, you can decrease the probability of disease. And it actually kind of follows the same general pattern. So 0.5 equals negative 15. 0.2 equals negative 30%. And 0.1 equals negative 45%. So they kind of track, you say, 2 and 0.5 kind of track 5 and 0.2, 10 and 0.1. So that's kind of how you use these likelihood ratio probabilities to estimate what your post-test probability is and how your clinical suspicion changed, whether that finding was positive or negative. And you can use likelihood ratios any findings. You can use them for, you know, it's most commonly used for physical exam, but you can also use them for lab tests and imaging as well. All right, so let's go back to this case. So I'll kind of get, maybe you guys can use the chat or talk out loud. What would you guys think are some of the differential diagnoses in this case? And I think there's a few, so, you know, you really can't go too wrong. And I'll open the chat. I'll have that chat open right now, just in case y'all are talking in there. All right, I got CA. Cancer. Okay, yeah, we got cancer. All right, so the question is here, you know, this guy's got some infiltrates on his x-ray. What do we think? What's some differentials of things causing this patient's shortness of breath? And I'll tell you, it's not going to be a fancy diagnosis in this case. Okay, I got PE for sure. And I think that's good. I didn't do PE in this case. I do have them on, I do have it on those flow charts. If you look in the note section under shortness of breath likelihood ratios. But yeah, COPD exacerbations, some research that, you know, about 15% of them are, you know, PA. All right. So John said usual bread and butter, pneumonia, COPD, and CHF. So for me, when I was seeing this patient, I think PE is on the differential, but we have infiltrates on chest x-ray. So we kind of know that there's probably some lung parenchymal process going on. Abdul, I'll give you the case. The patient didn't have like the anemia was, I think his hemoglobin was around 9 or 10. But let's say pneumonia, COPD, CHF. What do you guys think are the pretest probability of each of those? So let's start with pneumonia. What do you guys think about the pretest probability of pneumonia here? And this, I mean, honestly, just Abdul says high. Yeah, I think it's pretty high. We have an infiltrate on chest x-ray, right? Anyone want to put a percentage point on it to make it interesting? I think let's say pneumonia is around, it's pretty high, but you know, there's some infiltrates, but I like it 70. That's funny, Abdul. I was gonna say about to put 70. All right, so let's do 70 for pneumonia. Or what do we think about for CHF? And I'll go back to the case for you. Make moderate. I don't know. Is anyone suspicious? I like that. Someone said 40 to 50. Someone said 40. I like that. 45. Let's do 45 for CHF. All right. And then lastly, what do we think about COPD? He's wheezing, you know, but I don't know. He is a smoker. He is a smoker.
Wait, so what do you do about this if it's like an overlap diagnosis? So like maybe this guy had like a viral pneumonia triggered a COPD exacerbation, for example.
Yeah, no, I mean, for that, like, You know, you're right, because I am teaching diagnostic exclusivity right now, which, you know, you shouldn't really teach too much because multiple things can contribute to someone decompensating. But I think just saying this is a COPD exacerbation, like Fred, what do you think your probability of a COPD exacerbation for this patient is?
I agree with Mike, 15%.
All right, 15%, perfect. All right, so let's kind of go through. So what kind of things, I mean, I gave you guys some stuff already. We have the chest x-ray, you know, we have that the patient's wheezing. We have the general history, which is huge. What kind of things, and as you guys ask these, I'm going to tell you and I'm going to give you the likelihood ratios for those things. But when you're approaching these patients, what type of things do you ask for in the history, physical exam, vitals, labs, and imaging? What kind of things can be helpful? And this can go back to, like, you know, stuff you learned in cough and sputum production and fever. Perfect. So we got a good amount. So let's go through cough and sputum. Tara, I think, you know, you're saying cough and sputum production, just assume you're thinking pneumonia, right? So how much do those help pneumonia? So cough is a good one. Actually, one of the best ones for pneumonia. It doesn't help rule in, so it's not significant positive, but it's a 0.2 negative likelihood ratio. So not having a cough makes a 0.2 negative likelihood ratio. So that the patient did not have a cough. And then sputum is actually a little bit the same. You know, it's not really good for positive likelihood ratio, probably because it's not super sensitive. So it's not significant for that. But then rule out, it's like a 0.5. He did not have any sputum production either. So perfect. Those are great. So I keep saying people's name and it kind of ruins the like the randomness of the chats. I'll stop doing that. So let's do pro-BNP. So pro-BNP, I think we're thinking of systolic heart failure, right? So how helpful can this be? So it actually depends on your age. So less than 50 years old, then there's 50 to 75, and there's greater than 75. So for ruling in, you know, depends. So this guy's 65, so he is right here. So if they're less than 50, if it's greater than 450, they has a positive likelihood ratio of 15. So you basically almost like rule in some sort of heart failure. If they're 50, I mean, you still have to kind of think about other things that can cause, you know, LV or RV strain, like a PE, things like that. But, you know, it does help. 50 to 75, it has to be greater than 900. And that's a likelihood ratio of 5. And then for greater than 75, it has to be greater than 1800. And it's just less accurate at this age. And that's a likelihood ratio of 3. So he's 50, 75. It was, I think it was around 2000. And his likelihood ratio was positive 5 for that. So that's a pro-BNP. Next one's procalcitonin. This procalcitonin, I think you're going to hear a lot of things that you can use it, you can't use it. Maybe it's good for viral pneumonia versus, you know, bacterial pneumonia. Maybe you can taper antibiotics. But I think there is a lot of controversy around pro-BNP. Procalcitonin. I do use procalcitonin, but I use it in situations like this a lot of times where maybe they have pneumonia or maybe they have an atypical presentation of something else, right? Other things can cause infiltrates on a chest x-ray. Alveolar edema from heart failure can cause it as well. So, you know, I think it sometimes can be helpful. So and this depends on really where you look. I went with the most conservative one that made procalcitonin look the worst. And for a procalcitonin less than 0.1, less than 0.1. He was 0.05 or something. It has a likelihood ratio, greater than 0.1. Has a likelihood ratio of 2 and 0.3. So since it was less than 0.1, it's negative likelihood ratio, so 0.3 for the pneumonia. John, you gotta keep doing that. So asymmetric chest expansion is another one, only helpful if I've never done it as well. I probably should. And I think it probably only helps for really, really, really severe pneumonia, especially like a lobar on one side. But the positive likelihood ratio is like plus 44, and the negative likelihood ratio is not good. So he did not have that. I did do it here, but it's not significant, so it doesn't do anything to making it less likely. All right. Anything else going through these findings that you guys would be thinking of? Wheezing. Yeah, so wheezing for COPD, you think wheezing is like super good, and honestly I couldn't find any. I think this is just in the general population of people in COPD, but with or without an exacerbation. So wheezing had a positive likelihood ratio of 3 and a negative likelihood ratio of 0.5 for COPD. Not all wheezing is called by asthma and COPD. As you guys remember, things like heart failure or any sort of local foreign body or cancer obstruction can cause wheezing as well. Heart failure is mostly because it causes actually edema of the bronchial walls, and that edema increases resistance, which increases basically dynamic collapse and subsequent wheezing in patients with heart failure. So he did have wheezing, so that increases our COPD by about 3. All right, anything, and we can do imaging, we can do labs, we can do so let's go through like this super random pneumonia stuff, right? So we did this all the time in medical school, where you did like agophony and you did bronchial breath sounds. So those can be helpful, but really only if they're present. So they're just like not. I think they're just not sensitive enough that you really can't rule it out if they're not. If you can't rule it out if they're not present. So agophony has a likelihood ratio of 4, but without it, it's not significant. He did not have agophony. The next test is bronchial breath sounds. That had 3 and then NS. So he didn't have that, but it's not actually super helpful. They're really, and it's good to listen and try to hear those things, but they're only helpful really if those random physical exam findings are only really helpful if they're present. So Grodsky, we're talking about infiltrate on chest X-ray. So this is really the gold standard for diagnosing pneumonia, is an infiltrate on chest X-ray, which is like, with other findings of infection. But I mean, the diagnosis of pneumonia and the gold standard is just so low. There's so many other things that cause an infiltrate on chest X-ray, and I think that's one of the reasons why all the studies on procalcitonin are so controversial and they're so different from each other, because they all had different ways actually of diagnosing pneumonia. So I couldn't find it, but I did find that it had probably about a 95% positive predictive value for pneumonia. So that's kind of how much that may help. And then for the chest X-ray for imaging for systolic heart failure, this wasn't called on chest X-ray, but the positive likelihood ratio of chest X-ray with interstitial edema and finding of heart failure is about 12. The negative is about 0.4. So they did not call any interstitial edema. They did not call any signs of heart failure on this patient. So they had a negative likelihood ratio of 0.4 for heart failure. All right, and then we got leg swelling. So I always thought leg swelling would be pretty good for systolic heart failure. It's actually not that great. So a lot, and I think you do see this not so uncommonly, that patients present with heart failure and they may not have leg swelling. And then other things can cause leg swelling. You think about things that decrease oncotic pressure, like liver disease, nephrotic syndrome, and even patients just have vascular insufficiency in their legs. So leg swelling has about 2, and 0.6. So he did not have any leg swelling, which was like not even that good, but it made this a little bit less likely that he had heart failure. JVD. So JVD is by itself, just looking at someone's neck and looking for JVD, that's a positive likelihood ratio of 4. And the negative actually isn't very good. But once you add the abdominojugular reflex, it actually becomes extremely good. And the positive likelihood ratio is 8, and the negative likelihood ratio is actually 0.2. So this should be something you should be doing on every single one of your patients. It's actually one of the best physical exam findings for heart failure itself. Actually, just one of the best findings in general for heart failure stuff. So abdominojugular reflex, always add that into your JVD. Probably don't have enough time to go into exactly what you do, but you know, you guys can look it up after this if you don't remember how to do it. So that one's huge. He was really obese, so I wasn't really able to get these. So I didn't feel like I was able to get these findings. You can do it with an ultrasound, which I did do it with, but I'm not going to present that here because most people don't have an ultrasound. All right, anything else? And I'll go back to the case for a second in case you guys want to look at it a little bit more to make you give you some ideas. Does anyone remember any like the weird physical exam findings for COPD? There's a couple really interesting ones. Buboter and puffer. Yeah, so the chest shape. Yeah, the chest shape it's okay. So barrel chest, it's like a positive likelihood ratio of 2, I think, and it's not that significant if it's not there. So Sean said hyperresonant. So hyperresonance is a big one. So and the way you actually do this is you take, so he didn't have a barrel chest, but that wasn't too helpful here. You actually take, you basically, it's hard to do, but you go for the right upper chest and you do percussion here. And if it's really hyperresonance, that has a positive likelihood ratio of 5, but not really a great negative likelihood ratio. Clevicular lift is one of my favorite. And I actually didn't know until I did this how good a clavicular lift is. And the way that they say clavicular lift and the way to judge this is actually, so when patients have COPD, their clavicles come up because they are, obstructed and they're having retainment of air in their chest. So what that does when their clavicle comes up is it actually makes their clavicles a bit closer to their sternal notch. And if they have a area between their sternal notch, just right above your Adam's apple, and their clavicles, and if it's less than 4 centimeters, this is actually pretty helpful. So that has, so sternal to clavicle, less than 4 centimeters. If they have that, it's a likelihood ratio of 4, but it's not super sensitive, so it's not super helpful if they don't have it. So he didn't have hyperresonance, but it wasn't helpful. He didn't have that sternoclavicular, which wasn't helpful. So one of the ones that, and I got this from the book, Evidence-Based Physical Diagnosis from McGee. So one of the really helpful ones is called the forced expiratory time. And I've seen one pulmonologist do this. So what the forced expiratory time is basically you take your stethoscope and you put it on and you put it over the patient's neck, like this. And then you ask the patient without no, I can't think of the word. Without pursed lip breathing, you ask them to breathe out as fast as they possibly can. So they do that, they breathe in. So you see, I basically was able to breathe my full air out in about 1 second. Really good question, Madison. Are these helpful for COPD exacerbation? I couldn't find a lot of these specifically for a COPD exacerbation. I think the one that I'm not too sure about, which is helpful in a COPD exacerbation, is wheezing, to be honest, but these are for COPD in general. So knowing if they just have COPD in general. This is one of the things that I wish I had, especially for wheezing, what the discriminant, the likelihood ratio is for that. But for forced expiratory time, the way that you do this, so if they are able to, so if it takes greater than 9 seconds, this is super helpful. So it has likelihood ratio, positive likelihood ratio of 4. And if it's less than 3 seconds, then it's unlikely they have any obstruction, and it has a negative likelihood ratio of 0.2. So I did it for this patient, and it has a negative likelihood ratio of 0.2. So making it less likely that he has COPD because he was able to breathe all that air out very, very quickly, making it look like he has really no obstruction. The other one in COPD is, and that we didn't ask, is what's this guy's pack years? So pack years can be really, really, really helpful in diagnosing COPD. So the cutoffs that they use is less than about 15 to 20 pack years. And I couldn't find a specific number for this, but I heard very unlikely. And then the other question, and then the cutoff for making it more likely is greater than 40 pack years. And this has a positive likelihood ratio. It's high, about 8. So he actually only had about 5 pack years. So he falls into this. So super helpful at asking pack years for COPD. He said he only smoked a little bit when he was younger and kind of quit, not too long ago. There's not really many good labs for COPD. The PFTs are pretty good. Well, they're the gold standard for diagnosing it. So 6 and 0.1. And then imaging, can chest x-ray help you for COPD? So it doesn't help rule out COPD because it's not sensitive enough. A chest x-ray is not sensitive to find those emphydematous changes. So likelihood ratio of 4 and then a negative likelihood ratio of not that well. But he actually did have a previous CT chest that he got, I think, maybe like a year ago. And it actually had no emphysematous changes whatsoever on it. And that can actually be helpful because it is more sensitive for finding those changes. So looking at a previous CT for someone with COPD can actually be helpful for making it a little bit less likely. All right. So I think I have most stuff here. The only other ones that I'll say, because I don't think we have too much time left. Other things to ask were orthopnea and PND for CHF, and these are helpful. So orthopnea has a likelihood ratio of 2, negative likelihood ratio of 0.7, PND 2.5, and a negative likelihood ratio of 0.7. So he did not have any orthopnea, which isn't super helpful, but he did have PND. The other ones, I think those are probably most of our most helpful findings. The other one that I think is nice for pneumonia is does a patient have completely normal vitals? So having abnormal vitals for a patient for pneumonia doesn't help you, right? Because most people should have it. But if they have completely normal vitals, then the negative likelihood ratio of them having pneumonia is 0.2. So he fell into here, which I think, kind of makes sense. All right, so let's try to go back to what we did and try to actually add these up. So let's go through pneumonia first. So we thought his pneumonia was, what was it again, 70%. So he didn't have a cough, so that makes it 0.2. So if you remember, 0.2 is negative 30%. Didn't have any sputum, which is 0.5, so it's negative 15%. These didn't really help us at all. Didn't help us at all. The physical exam was pretty much useless. for pneumonia, which sometimes it, sometimes it can be. The procalcitonin was 0.3. So that would be about negative 25%. All right, so total is negative 60%. So that's our total that we just got. Let's go through COPD, and I think COPD is where your physical exam is very, very helpful, right? So first, I don't know how much this decreases it, but I'm going to say negative 30% because he barely smoked. This was super helpful, negative 0.2, so negative 30% for COPD. He did have wheezing, which was 2, so that's probably about negative 20%. None of these really, the other ones weren't really helpful. We didn't have PFT, so that wasn't helpful. And we did have a previous CT that did not show any emphysematous changes, so that made it negative 15%. So total for COPD now, we have, so negative 10, negative 40, negative 55%. So that's our total. And then let's look at heart failure. So this he didn't have orthopnea, 0.7, so that's like not a lot, right? Didn't really do anything for us, so negative 10%. He did have PND though, that's 2.5, so that's probably about positive 20%. I couldn't do these. The other ones that can be helpful is S3, but he didn't have S3, but S3 only helps you if it's there, which is likely ratio of 4. He did not have leg swelling, so that decreased it by about 10%. Labs, his NT-proBNP was high, so that's 0.5, so that's about positive 30. So far what we have is positive 30% around for heart failure. So we haven't really, and we started at 45%. So, we haven't really totally proven heart failure yet. But we didn't do one thing which can be extremely helpful in diagnosing heart failure. And that is doing an ultrasound looking for B lines. So this was his ultrasound here. And these are basically B lines everywhere. And what B lines, on ultrasound, they're the same pathophysiologic mechanism as from a chest X-ray, in which this is secondary due to interstitial edema between your secondary pulmonary lobules from lung congestion. So he did have this. So how do we incorporate ultrasound into this? Well, actually, ultrasound is one of the most, and B lines can be one of the most helpful things in diagnosing heart failure. There's other things that can cause B lines though, right? So non-cardiogenic pulmonary edema like ARDS do it. Multifocal, B lines will usually just be in one area if they have pneumonia. It won't be bilateral. His was bilateral, but if someone has multifocal pneumonia, that can do it as well. But for heart failure, B lines were present on ultrasound, and this actually had a positive likelihood ratio of 10, which made it plus 45%. So overall, plus 75%. So let's kind of go back to our to this. So we're actually not going to use likelihood ratios too much right now, but let's do COPD. So we just rolled out COPD, right? So COPD is negative 55%. It was only at 15%. So now I don't even know it's probably at 2 or something. So 2% chance that the patient has COPD, even though he was admitted for pneumonia causing a COPD exacerbation. But so many people did get this diagnosis of COPD and no one ever did PFTs, and they don't even have physical exam findings consistent with it. So always something to watch out for. It's a very common loose term. So COPD is not likely anymore. Let's do pneumonia next. So pneumonia we thought had a pretty high, and I think that's fair. We had the chest X-ray with an infiltrate on it, which is the gold standard for diagnosing pneumonia. That's 70%. We just dropped it by 60%. So we are now at 10% for pneumonia. All right, so pretty unlikely. And then let's go to CHF, which we thought, maybe. And there was some stuff in the history where you thought maybe the CHF. I think the big one for me is that he got and why I started thinking about this initially is like, did the last time he come in, he have a component of a CHF exacerbation? I mean, he was only given 1 unit of blood, and then he developed such bad pulmonary edema that he actually had to go to the ICU. So I thought probably part of his admission last time was maybe secondary to CHF. And that's kind of what made me thinking about it. And then he also had a history of, MI, which increases the risk of someone having CHF, because most CHF is going to be due to ischemic cardiomyopathy. So that's kind of why I was thinking about it originally. And, we probably put that at a moderate place, but after we did everything from 50%, we just made it, basically we just completely proved it. So it's almost somewhere probably between 95 and 99% for CHF. And that's really what the diagnosis was. He went and got an echo, and the echo showed probably had ischemic cardiomyopathy, and he had a EF of around like 40%. But you can't always rely on the echo too, because that's only for systolic heart failure, and half of heart failure is diastolic, and the echo is not super sensitive for diastolic heart failure. And then I looked back at his chest x-ray too. And, over on the left here, his chest x-ray from 2 years ago, and you can see, it's pretty clean. But then you look at his chest x-ray on admission, and, he did have interstitial edema. So you can see that basically his, pulmonary vasculature goes out pretty far to the periphery. It's much more apparent on this new x-ray than it is on the old x-ray. And then, I think at the end of the day, we diuresed him, and all of this actually went away. So it actually probably ended up being just some atypical pulmonary edema. And it was fixed just with diuresis, gave him Lasix, and he felt a lot better. And his x-ray findings improved. And this is a big one too, because 30% of the time, you're not going to see edema on a chest x-ray. So, chest x-ray for heart failure, helps to prove it. But if it's a negative chest x-ray, you can't always rule out heart failure with that. And the reason why is people think pathophysiologically, they, people with heart failure, they have hypertrophy of their lymphatic system. So they start draining a lot of that blood through their lymphatics to decrease pulmonary congestion, and which makes the chest x-ray negative. All right, so all this will be on those flow charts that I made. It's in the likelihood ratio section for shortness of breath. But any questions at all? All right. Thanks, everybody.